A very good morning, everyone. Thank you for joining me in the second session of this morning lectures. My name is Raja Elina, President of the Malaysian Association of Clinical Biochemists, and I will be moderating this session. We are fortunate that we have two eminent speakers with us to speak on two very interesting topics. For the first lecture, we have Associate Professor Dr. Sunil Sethi. Welcome, Prof. Sunil. Thank you so much for participating in ACBRLM. Before I hand over to Prof. Sunil, let me first briefly introduce Prof. Sunil to you. Prof. Sunil Sethi is currently the Group Chief or Laboratory Medicine National University Health System and Group Director, Applied Sciences Group Health Sciences Authority, Singapore. He is an internist and chemical pathologist holding appointments as Senior Consultant and Head Division of Clinical Chemistry, Department of Laboratory Medicine, National University Hospital, Singapore. He is currently holding the position of Executive Board Member of the International Federation of Clinical Chemistry, the IFCC, President of the ASEAN and Pacific Federation of Clinical Biochemistry and Laboratory Medicine, APFCB, as well as the President of the Singapore Association of Clinical Biochemists, SACB. Without further ado, let me now invite Prof. Sunil Sethi to deliver his talk entitled The Burden of Chronic Metabolic Disorders and Real-Time Monitoring of Diabetes Mellitus. Prof. Sunil, the floor is yours.
Thank you, Elena. Thank you. Good morning, everyone. Can you hear me?
Yes, loud and clear.
Good. Let me try and see. Can you see my slides?
Yet.
Are you able to see the title slide?
No, not yet.
Okay.
Yes, we can see
Now?
Yes.
Okay. Good morning, everyone. Thank you, Elena. Elena and I go back a long way. We work in a number of committees. I thank and I'm want to congratulate the organizing committee for the ACBRLM. I think it's wonderful to do such a meeting under so difficult a condition. And this remote model of presenting is new, but probably going to be the way of life. I hope we get out of this situation sooner rather than later. In the interest of time, let me just go and now talk about, diabetes, chronic disease, often called the mother of all disorders. Before COVID came along, this was on everyone's tongues. Now with COVID, I think we've forgotten quite a bit about it, but let me then just refocus. I want to scope things by very quickly addressing the issue of the population in our part of the world. Asia holds 60% of the world's population. We are about 4.7 billion out of a total 7.9 billion in the whole world, amounting to 60% of the population. So that, in a way, is significant, but more significant than that, the elderly, in other words, 60 and above, in Asia is unprecedented. We've got more elderly patients, elderly people rather, compared to the rest of the world put together. So now with this, in terms of a big population and an elderly population, I think Malaysia is doing quite well. Essentially, we've got countries like Japan, South Korea, in fact even Sri Lanka. The aging rate is tremendous. Malaysia is doing quite well, but with aging comes many challenges. The demographic in itself brings the burden of chronic disease into focus. We don't have enough resource in terms of bed, infrastructure, healthcare professionals just to manage that huge number of chronic diseases. And of course, the mother of all chronic diseases is diabetes. And if you look at certain statistics, now this is US data, but just focus on chronic disease, diabetes, hypertension, congestive cardiac failure, and coagulation requirements for anticoagulation. They sap so much of the healthcare spending. and more than 90% of all prescriptions, would you believe it or not, is just to manage chronic disease. And of course, with a large population which is elderly, this is going to be a big issue in our part of the world. Now, very quickly, I move into the topic which I'm supposed to cover, which is diabetes. Many of us are familiar with the usage of, glucose monitoring, and of course, the revolution of uh, the ability for us to manage uh, glycemic control by the use of glycated HbA or hemoglobin or HbA1c. And we knew, for more than 20 years, for the diabetes control and complications trial, the DCCT, the A1C is related to a number of the chronic complications of diabetes, whether it's renal, eye, peripheral neuropathy, cardiovascular disease, strokes, heart failure, and ultimately even mortality is related to glycemic control. And our aim has all along been to make sure that our patients' HbA1c levels are within target and ideal so that we either delay or eliminate the complications and, of course, allow many of our diabetics to have a full and healthy life. So, this is essentially has been our aim, our purpose. And with some of the new modalities, we now realize that diabetes requires us to manage the entire spectrum of the healthcare uh, available resources. You will know and you will appreciate very quickly that diabetes requires a large degree of preemptive counseling. So even at the early stage, towards the bottom left of this slide, you'll see a lot of prevention, early intervention, avoiding obesity, encouraging good lifestyle so that we avoid or delay the onset of pre-diabetes and then diabetes. And then once they come on to diabetes, we need to manage them perhaps in the outpatient setting, simple medication, lifestyle, assessments. And a diabetic, if he develops a complication requiring, say, an acute wet gangrene of the lower limb requiring, unfortunately, an amputation, we bring him up to an acute care setting, do the surgery, and the minute he's recovered, we need to bring him down to a step care, a rehab facility, and then back home into the community. So you can imagine there is a lot of integration required. And if we don't do this, you can imagine large numbers of diabetics causing significant chokes. And the worst thing is, hospital beds, intensive care beds, these are precious commodities. We can't allow patients to choke them just because we don't have downstream facilities. And you can imagine the continuity of care is vital in such patients. And I'm sure it becomes very apparent when we've got high volume issues like diabetes. And how do we manage these patients real time? Now, in Singapore, one of the big value adds in the ability for us to have continuous care is now the live setup of what we call the NEHR, as you can see in this slide. This is the National Electronic Health Record. Now, every aspect of a Singaporean and a permanent resident, we've got about 5.28 million in our small country. Every one of these records, from the time a Singaporean is born, the neonatal vaccinations to every single emergency, inpatient, outpatient, every lab test is captured electronically and is available to any healthcare giver in Singapore at any location, which means a lot of the patient's electronic results are all captured. We don't duplicate, we don't miss, we don't get alerts, we don't miss alerts. For example, in terms of allergies, drug requirements, etc., etc. So now this is an important step, which then integrates community care with acute hospitals to step down facilities to the general practitioner to nursing home requirements, etc., etc. So in one view, any caregiver can see where a patient is in terms of his healthcare journey throughout his life. Now, in laboratory practice, chronic disease management is something which we need to support as a lab fraternity, and we are doing it very well. In fact, we have revolutionized a lot of the way in which chronic disease is managed by virtue of some of the new technologies which are available to us. And today, in this short few minutes which I have, let me just try and give you and make you excited about what is potentially uh, the lab offerings in terms of the management of some of these chronic disease, how we manage them, how we help in prevention, and how we provide a connected healthcare environment. Now, two big areas in laboratory arena, which I want to highlight to you. Number one, point of care diagnostics. Very interestingly, we've got smaller, more accurate, more real-time gadgets, devices, toys, tools, put at the hospital, put in emergency department, put in ICU. Now, of course, used even in primary care settings and even in the home. They are less invasive and, they allow connectivity and they allow a lot of real-time capability in terms of lab diagnostics. We take point of care a little bit sophisticated. And I can tell you that now biosensors and trackers, which are wearable, we are all familiar. You wear this when you exercise, you count your steps, you count your calories, whatever, but sensors are now going to be, in addition to wearable, they're going to be implantable. Okay. And, in 2024, we expect, perhaps when life goes back as per normal after this pandemic, that we will have more wearable, more implantable sensors, and predictions are made that all sorts of things can be tested real time. So this is one interesting aspect, the biosensor arena, and the other aspect is telehealth. Now, combining the two, allowing e-information, allowing all sorts of technologies to be transmitted in a real-time mode, are complementary technologies which allow quite good enablement function, and it serves the chronic disease arena very, very well. And I'll give you some examples of this and what is live in my hospital, in my cluster, my healthcare arena. Now, for the topic, very quickly, for diabetes, I wanted to cover this aspect of what we call continuous glucose monitoring. It's not new. It is also not old. The first registered CGM or continuous glucose monitor was FDA approved in 2017, 4 years ago. And essentially, I just highlighted four here in the top right corner of the slide, four different IVD vendors who have four different continuous monitors in slightly different modes. The one which I think is most familiar to us in this part of the world is the Abbott Freestyle Libre. Now there is a version 2. It's slightly, better, more enhanced, perhaps can stay a bit longer. It's a 14-day on-skin, sort of, flash glucose determinant, and it gives real-time uh, glucose monitoring. Then there's Dexcom, which is a sophisticated, also a 10-day continuous monitor. Some of us may be familiar, of course, with Roche because it's one of the vendors which support us in a big way. But the original company is Sensionic, and they produce this implantable sensor called Eversense. It's implanted by a healthcare professional. It stays in place for about 3 months. Now, the newer version, about 6 months. And it gives continuous glucose monitoring. And the value of this is something which I want to highlight in terms of real-time testing. And of course, the fourth one is Medtronic. But in any case, this is now new technology. This is new modalities which, in my mind, are very exciting. Not only is this a diagnostic, I can tell you that many patients use this in a way as a pseudotherapeutic. In other words, if you have real-time glucose and you put your handphone there and you see your glucose moving, say in real time, and you have a meal, you will straight away know whether the meal is good for you or not by your glucose search. And in that sense, this diagnostic becomes therapeutic. It moderates, it modifies, it changes your lifestyle because you yourself will know whether this is a meal which dumps glucose because of a high glycemic index, or it's a meal which is suitable for you, and then you moderate your lifestyle. So this is exciting only in that sense. But these sensors do all sorts of things. They will help you throughout the day. And the problem with a lot of these sensors is that we are able to manage glucose and we are able to try and then make some sense of the surges, but we need to manage essentially the vendors have got two areas to manage which make it difficult for us to moderate our glucose. One is for exercise and the other one is after meals. Okay, so this is the Eversense, the Roche Eversense 3 months implantable. Yeah, if you exercise, you'll know whether you go hypoglycemic or hyper. When you sleep, you can have alarms, you can have triggers, which allow a person to have very tight glycemic control. At the same time, not worry about going hypoglycemic when you're asleep and not having any sort of food intake. Now, I put up a slide on real-time monitors, potentially which can benefit a patient. Now, you'll be surprised just looking at this that these are what you wear, what you implant, what you eat, or you consume. The red dots are already now in 2021 available for a diabetic or for anyone. Continuous monitoring, continuous ECG monitoring, applications, a smart weighing scale which gives you all the details, smart socks for diabetics, particularly for temperature, inflammation, and uneven sort of pressure points, and artificial pancreas. This is already available. Smart watches, continuous BP monitor, uh, contact lenses which do sort of vitreous which do glucose sensing, as well as smart drugs which look at the actual sort of environment in the GI tract, are things which are also up and coming. So you can see, it's a different world now, and all of us, as individual subjects, in a healthcare environment, can be very, very richly monitored in real time because of the technologies. And I'm delighted that the lab is front and center, because these are all diagnostic tools which allow us to basically monitor and to manage patients. Now, because of continuous glucose monitoring, I'm not sure whether all of us are aware, but there is now a new, very exciting uh, aspect of diabetes management, and this is what we call time in range. Now, you can well imagine that if glucose is done instantaneously over a 24-hour period, then instead of looking at A1C, which gives us the average of the preceding 3 months, we've got a continuous range of sugars or glucose over the day, which we can then track our patient. Now, a time in range basically then just has a consensus, an international consensus, professional body, which then purports that, look, over a 24-hour period, at least 70% of the time, a person's glucose should be within 4 to 10 millimoles per day. In other words, this is the range which we want. And evidence then suggests that the longer this target, a time in range, the better the glycemic control and the better what we call the estimated A1C is, and a better endpoint in terms of complications and mortality. So you can see in future, something like this would be the norm when we look and we track and we monitor or we treat our diabetic patients. We will see a continuous 24-hour monitor. We will look at the period. We will study whether the person has significant time in range, what is the percentage, and what is the estimated A1C. Now, in patients, say black patients who've got a lot of, hemoglobinopathies, A1C is artifactually affected. And in patients who've got poor sort of ability to use A1C, time in range is now going to be even more valuable. So this is a nice real-time monitor. This is a nice real-time application for some of the technologies which are currently available. And if you then integrate it into a system which detects, digests, uses a logic to then interact with another medical device, say an insulin pump, then for type 1 diabetics or poorly controlled type 2 diabetes who require insulin, you would find a continuous closed loop, which will allow very close to physiological modeling of the control of glucose by insulin. And these are already now going on, and these are really indeed revolutionary uh, technology developments which have change the prognosis, change the outlook and the outcome for diabetes in a very big way. In terms of decision support, I just wanted to highlight something which we did in the lab here in my hospital in Singapore, very quickly in the interest of time, just to say that, because a diabetic is so prevalent, and in primary care settings or in any setting, many clinics, because of the large volume, have got doctor or healthcare interaction with diabetes only maybe 2 to 3 minutes because of the large numbers, as I mentioned, in our part of the world. And what we did in very quickly is we allowed an application to aggregate all the data from a patient, uh, and we allow the doctor, when he sees a patient, to have a very quick snapshot. Very quickly, I can tell you that there are at least 11 different biomarkers which a doctor needs to monitor for a diabetic, from lipids to glycemic control to A1C to renal function to urine albuminuria. Now, what we've done in this dashboard is very simple. We just tell the doctor, look, you look at all the red dots. If it's red, means the person's marker is not in control, you focus on that. If it's green, means it's all right. If it's blinking, means it's not current. If it's a solid color, it's current. So very simple. We put everything up front for the doctor. When he sees the diabetic, he doesn't need to toggle the results, toggle the blood pressure, toggle all the parameters. Everything is given. And this is essentially a dashboard which we've covered. And I, had very, very positive, comments from all my primary care physicians and the endocrinologists who have piloted this application. So I would then now like to challenge anyone, so, in your environment, if you don't have something like this, develop. It's not difficult. It's an aggregation of data using an IT application just to make life simpler for the doctors, and then the patients benefit, because even in the 2 or 3 minutes, you don't miss. You focus clearly on the targets which are not being achieved. Telehealth, I want to end by saying that in my environment, we've got a telehealth cloud. And for chronic disease, I can tell you a lot of the patients just do their own thing. And I just wanted to share the model for 4 different home devices. You can imagine 4 devices. Number 1, a weighing scale. Number 2, a blood pressure monitor. Number 3, a glucose monitor. And number 4, a PT-INR monitor. Okay. Now, these are things which patients use at the home. Each of these devices in our clinics, we have put in a 4G SIM card. And when a patient, for example, steps on the weighing scale every morning, the patient's weight is transferred into a secure healthcare cloud.
Online.
Hello. Okay, so what we do is the patient with chronic congestive heart failure steps on the weighing scale. His weight is transmitted through a secure cloud to a pharmacist who looks at this. Currently, it's my pharmacist, real time. And if the patient's weight has gone up above a certain threshold, say more than 750 grams over the last 24 hours, we know that the patient perhaps could have put on water weight in terms of accumulated fluid. So the pharmacist will call the patient and say, are you well? Are you okay? Are you breathless? Can you lie flat? Have you got swelling of your feet? Have you got chest pain? The patient then answers the question. The pharmacist will then counsel. If the patient is unwell, we can send an ambulance. And we know this real time, because in heart failure, you tend to accumulate water and then you tend to go back. Same with blood pressure. Why is your blood pressure high? Did you take your medicine, etc., real time? Same with glucose. If it's hypo or hyper, you get a pharmacist calling. And same with PT-INR. Whether you're under or overcoagulated, you get this. So this is real-time telehealth, real-time monitoring of chronic disease. We counsel patients. We find that up to 25% of our patients don't need to be seen, even when the numbers are off. They can be counseled and then avoid coming into hospital. So it's interesting, and it's a good way of looking at them real time. So these are some examples of how technology can improve and allow us to do real-time tracking. In conclusion, I just want to say that a holistic approach from government, or healthcare providers is important. Why? Because we need to do across the healthcare landscape, the environment, holistic management of our patients from the time we look at uh, their healthcare journey to acute care, to step down, to convalescent, or maybe even palliative care. We do need strategies for assisting and preventing illness. And again, the diagnostic things like continuous glucose monitors are very good at early diabetes, at prevention of deterioration, prevention of complications. We need healthcare to be provided at alternate locations. And what better alternate location than to be at home, doing what you normally do every day, and at the same time be reassured that you are being monitored from top to toe. And looking at the potential, you literally can be monitored from top to toe on a daily basis. And you don't have to go and do anything extra from what you've been doing. Use digital technologies, use newer modalities, and the lab is front and center of this. And I can say that the lab really has a very bright future. And those of us involved in the lab arena, go and get yourself licensed and registered, as what the previous speaker said, and have a fulfilling long career in laboratory diagnostics. Thank you very much for your attention, and I'll be very happy if time permits to have a discussion. Thank you.
Thank you, Sunil, for that very interesting and informative talk. I've always enjoyed listening to the progress that you have done, and I must congratulate you and your team, for the how you have managed to use new technologies to improve how lab can improve, services to the patients. Before we go, to questions from audience, I would like to start with asking you, how involved are you in managing actually patients? Do you actually go out and also meet patients and teach them how to use these devices? And we know that lab personnel has always been the backbencher, but how has this new technologies changed the way you work?
Okay, very good question. Thank you very much. Personally, on a personal basis, I take a lot of fulfillment because I see patients directly. Okay, so I run a lipid clinic, so I am a user of my own lab services, and I know how good or how bad or how poor my turnaround time is in real life. So when I talk to my team, they understand because they know this is real life good. But in a broader context, I feel that lab professionals now, lab staff, technical lab staff, are seeing more and more, not so much as direct patient care, but more and more assisting in my remote units, meaning my A&E, my ICU, my point of care, talking, looking at rapid tests in a very big way. And we are now more and more comfortable with interacting with our clinical colleagues. And my core lab is fully automated because, again, on another facet, that's another one of my most interested areas is total lab automation. We allow a lot of the staff to be freed from the mundane processing, the pre-analytics, either spinning, aliquoting, and then running. But because they are freed from this, we spend more and more time looking, interacting, and talking, and trying to do data analytics. And this is, I believe, the future of laboratory professionals, the value added component. We've got a vast degree of data information. We need to make sure that we are now going to be registered in a bigger way, more professional, and we should operate on the high end of our capability as professional technologists, and we are moving that way. Not so much patient, Elena, but more with our clinical colleagues, I see.
Yeah, maybe wait, there's one time for one more question. How did you prepare your laboratory staff towards this, this way of working, use of new technologies, looking at digital data, how did you go about preparing them?
Okay, firstly, I got as many of them involved in the project team as possible. We developed together, we piloted together, and then Identify. I think identify people who can be change champions in the lab. One or two people who are excited, they can see, the younger ones perhaps, then, they come in, they are influenced, then they will be a bit infectious to the rest. And they will say, do this, do that, do this, let's get a TV, let's get a dashboard and all that. And that's how it becomes socialized in the lab. And that's how you then entrench it as part and practice, of the lab. So that's how we have done it. Yeah.
You talk about patient being monitored on real-time monitoring. Does that include all the patients or selected patients who are high risk?
No, you're right. The patient profile needs to be looked at. Somebody who's motivated, someone who understands, someone who's receptive to real-time monitoring. So we have a cohort now, if I'm not wrong, about 200 people in my hospital on chronic disease program, which we do this, not on a big scale. We are still refining it. There are some issues, like the healthcare, data protection and this and that. But yes, choose your subjects so that the pilot can kick off, and then we get more and more support by collecting data which suggests that it is a good program. Then I sell it to the ministry to fund it more and to expand it more. So yeah, at the moment now my hospital is about 200 people, but you choose your people correctly. The pharmacist is on the receiving end because the pharmacist knows medication, and we want to titrate medicine. We just don't want to listen to them. We just want to make sure that we do have some change. So yeah, so
Okay.
that I don't know whether that's answered the question.
Yeah. Thank you. There are some questions actually in the chat box, but we're running out of time. So if you could help to answer. So thank you so much for that lecture. I hope that we will have you back in future conferences. Take care. Stay safe.
Thank you. Thank you, and my best wishes to everyone as well. Thank you. Bye-bye.